All right. Good morning, good afternoon, everyone. My name is Andrea Hawkinson, and I am the Global Medical Affairs Lead for the Metabolic Health category with Nestle Health Science. I'd like to thank everyone for taking the time to join us today for today's webinar on intermittent fasting, weight loss, and type 2 diabetes, presented by Dr. Michelle Harvie. Just to give a little background. So Dr. Harvie is an award-winning research dietitian at the Prevent Breast Cancer Unit. She's been a leader in her field for over 20 years and has over 74 peer-reviewed publications, including 12 clinical trials in the area of intermittent diets. Her current research is focused on testing low-calorie diets for the prevention and management of cancer, as well as management of type 2 diabetes. Her research was instrumental in pioneering the 5-to-2 intermittent low-calorie diet, of which has now been adopted by numerous dietetic departments and weight management centers across the UK, and that includes Tier 3 weight management services. In today's webinar, Dr. Harvie will discuss the application of low-energy restricted diets as part of intermittent fasting and as an alternative for weight management and type 2 diabetes. Dr. Harvie will also discuss the Manchester Intermittent versus Daily Dieting Diabetes App study, or the MIDAS, for which she was the principal investigator, and it evaluated the acceptability and effectiveness of an intermittent low-energy diet versus continuous low-energy diet in people living with type 2 diabetes. Following her presentation, there will be a live Q&A, so if you have questions during the presentation, please feel free to put them in the chat box, and then following her talk, we will then try to address them during that Q&A session. But before I hand it over to Dr. Harvie, I do want to make the disclaimer that this webinar is being recorded for educational purposes only and will not be distributed for any promotional reasons. So now it is my pleasure to turn it over to you, Dr. Harvie.
Thanks, Andrea. So so welcome everybody. Good morning, good afternoon. I'm not sure if it's evening for anybody. And it's my pleasure to spend the next, up to an hour talking and discussing what we know about intermittent fasting and its effect on weight loss, with a particular relevance to type 2 diabetes. And as Andrea said in the introduction, I'm a research dietitian, and for the last 16 years, we've been studying these intermittent diets actually at my place of work there at the Prevent Breast Cancer Unit in Manchester. So we've certainly got lots to talk about. So my disclaimer is that in the course of that, I've written 3 self-help books to help the public follow intermittent diets, the diet that we developed. And all the author proceeds go to the charity Prevent Breast Cancer to support breast cancer research, not to me personally. Okay, so the presentation is going to cover certainly what we know about intermittent fasting. What I prefer to call it actually intermittent energy restriction. And to put that in context with what we know about the normal standard approach of dieting, which is continuous, what we call moderate energy restriction, and then something there's been a lot of attention on recently, the sort of continuous daily, very low energy, 800 calorie sort of formula diets that have shown such a great efficacy for weight loss. And so I'm going to review the evidence for those 3 approaches, and perhaps with an emphasis thinking about how meal replacements compare to food-based diets. And then, as Andrea says, the last part of my presentation is going to present the findings from our MIDAS study, which is comparing intermittent and continuous low-energy diets in patients with type 2 diabetes. Okay, so I don't think it'll be a surprise to anybody on this webinar that the links between excess weight, adiposity, and type 2 diabetes are extremely well characterized. So we know that If someone's obese, they're at 7 times the risk of developing type 2 diabetes, overweight 3 times, and even modest weight loss of between 5 and 7% reduces the risk of developing diabetes by about 60% in those sort of diabetes prevention studies. But of course, it's not a new story. It's been known, over 200 years ago. Certainly, doctors were aware that if you could take somebody with diabetes and get them to lose weight and reduce their calorie intake, you could actually put them in remission, or they call it cure diabetes here. So this is Rollo and Cruikshank from 1797 talking about Captain Meredith. And so, highlights the point that they put him on a 1500 low carb diet for 3 months. He lost lots of weight, stopped passing glucose, and was cured of his diabetes. But they also highlighted another important point, that another officer tried the diet, but basically got fed up with it and returned to his normal diet. So, if people can reduce their weight, follow low-calorie diets, then, it helps diabetes, but people find it difficult. So what can we do about it? So the standard approach to dieting is to ask people to reduce their calories on a daily basis. And generally, this is by between about 25 and 30%. So this encompasses things like your 600, 700 calorie deficits, and things like your Mediterranean diet, your paleo diet, your keto diets. Whatever diet you're asking people to follow, effectively, you're expecting them to reduce their calories by about a quarter and do it for most days of the week. And these diets can be effective if they're properly supported, but at a 12-month point, typically you've only got sort of a quarter to a third of people still doing them, with a clinically significant weight loss of 5% in between 20 and 40% of patients. But one of the real issues with these diets is that although metabolic markers are improved because of weight loss, some of the metabolic improvements that appear to be there when people are following calorie restricted diets do actually attenuate when people go into energy balance. And so the question is can we do better? So we have the continuous approach here. So alternatives, which say I started and my team in Manchester started studying about 15, 16 years ago, was whether if people did an intermittent diet, so you're still reducing the calorie intake by a quarter, but instead of doing it every day, you have 2 days a week where they reduce their calorie intake by about 70, 75%, and then the other 5 days they eat normally. So you're getting the same level of calorie deficit. And this is our 5-2 diet. So we have 2 consecutive days together. There are different versions available. Another way of doing intermittent dieting would be alternate day fasting, which is a version that Christopher Varaday has done a lot of work with in America. And the other type of dieting is to reduce your calories by a lot. So reducing down by about 65% down to about 800 calories. But instead of doing that just for a few days a week, you would do that for a continuous spell of anything between 8 and 20 weeks. And then you have a spell of food reintroduction, and then you go back to normal eating. So just to put these in context, these are 3 different approaches that I'm going to talk about in this session. So this is showing you the estimated calorie deficit and predicted weight loss at 6 months if somebody were to have total % adherence to these diets, which of course is one of the big issues. But just with that in mind, so essentially you can see this is for an average man with a BMI of 35 who's sedentary. And so you can see that the daily calorie deficit is slightly greater over this 6-month period for the continuous low energy diet. But there's not that much between them. And the estimated predicted weight loss at 6 months, again, would be marginally better for the continuous, but again, not so much between them. And if we look at a woman, again, you're talking about an average calorie deficit, which is not totally dissimilar, with again sort of weight losses of anything between 9 and 10 kilograms. So these diets could, in paper, all perform very well, and with slight differences between them, but not so much. So I want to talk first about intermittent fasting, intermittent energy restriction, and why, back 16 years ago, we thought that it might be a really good idea to ask people to try and follow these diets to lose weight. So the two things that we were really interested in was whether, if you just ask people to focus on their diet for a couple of days a week, do they find that easier than thinking about the daily grind of dieting every day? And would it be easier for them to follow? And then the other question, which I've already alluded to, is if you're having spells of calorie restriction every week, do you maintain, at least on those days, some of those metabolic benefits you get in things like reductions in glucose and reductions in insulin and things like triglycerides? Are they sustained? So other things we and other people have been interested in, and there's lots of hyperbole around these intermittent diets and lots of reviews and lots of stuff on the internet claiming that intermittent diets are way better than daily diets for a whole load of reasons, and they're all listed here. And I can tell you that, certainly in terms of their effects on mobilizing specific harmful fat stores, maintaining lean body mass and metabolic rate, and improving insulin sensitivity, there is some data that they're generally the same, maybe with slight improvements in insulin sensitivity in some studies. The rest of the things on this slide have not actually been properly evaluated, and they're out there for for evaluation, with the exception of, I should say, of metabolic flexibility. There is some evidence that people that do intermittent dieting perhaps are better at responding to spells of being fed and not being fed, which is a great interest. So intermittent diets are very popular, and this slide is summarizing a recent American survey conducted April, nearly a year old, April last year, showing that intermittent fasting is still probably the most popular form of fasting. Now, I will acknowledge that some of the intermittent fasting talked about on this slide is probably time-restricted feeding, and I'm not going to actually specifically summarize the evidence of that, partly because there isn't that much yet. We can come back to that in the questions if people have specific interest in time-restricted feeding, the idea of the fact that you're only eating within a few hours of the day. It's not something that we specifically studied, and I say there's not that much evidence for, but anyway. Intermittent fasting is still the most popular form of dieting, and I'm just showing this. This was a Swift study, which was a study of 250 overweight or obese subjects in New Zealand, and they were given a choice of different diets. They were asked whether they wanted to do an intermittent, a Mediterranean, or a Paleolithic diet, and you can see that actually more patients went for the intermittent diet. And okay, at 12 months, they weren't all still following it, but you can still see, a third of patients were still following it, and their weight loss was actually more significant than the other groups. Now, this is not a randomized trial, but it just shows that people are keen on following these diets, and they can follow them with successful weight loss. So how does this all pan out if we compare? Is an intermittent diet easier for people to follow and better for weight loss than a continuous diet? And this is from a recent overview, which included studies of patients with type 2 diabetes, but mainly non-diabetic studies. And it's a systematic review. So basically, if intermittent dieting was better, you would expect to see the lines over here. If the continuous was better, they'd be here. And basically, there is a very small improvement with the intermittent diet, a very small improvement, but nothing of major clinical significance. And actually, when you break that down, what you can see is that in short-term studies, this is a separate review which actually split trials of intermittent and continuous energy restriction into short-term less than 6 months and studies of more than 6 months or greater. And in the short term, certainly these diets are slightly more effective, but that difference disappears with time. And by 12 months, there's really no difference between them. And I should say that most of these studies, that these do include some of our studies, the long-term data is often without supported follow-up for either diets. So, you know, the question that we don't know is whether if you support an intermittent diet and you support a continuous diet, whether the intermittent might do better. It may well not. Okay, so what about the metabolic markers? So again, there is, from these overviews, there is a suggestion of a slight improvement in fasting insulin and HDL cholesterol, but again, possibly not of major clinical significance. And it's important to note that these metabolic markers need to be measured away from the diet days, because you will get acute benefits in insulin. So these slightly beneficial effects are seen away from the fasting days and on normal eating days, and you will get some improvements on the fasting days. So they're certainly not metabolically worse for people, but they're not vastly superior. So what about in type 2 diabetes? So the best study that compared intermittent to continuous energy restriction with sort of food, these are both with food-based diets, as they all have been up to this point. So they compared a 2-day a week of a 550 calorie diet to a daily diet, which actually had an overall slightly greater energy restriction. It was reducing to about 1,350 calories for 7 days a week. And they studied patients with type 2 diabetes over a year, where they had a supported program, and then 12 months where they didn't give them any support. So the graphs you can see here actually show that certainly by the end of 12 months, the HbA1c was reduced. It's a bit misleading because you haven't got the baseline point in here, so it looks like everything's getting worse, but believe me, the HbA1c dropped by about 0.5%, and they were losing about 7% of their weight. But you can see that both groups, in the between 12 and 24 months without support, both groups were going the wrong way and were regaining their weight. So at the end of the 12 months, there was no great difference between them, except that the patients on the intermittent diet were on slightly less diabetes medications. So what about continuous very low energy diets? So these are diets that have been received a lot of attention recently in the DIRECT study and the Susan Jebb paper. The name completely eluded me then. Anyway, it'll come to me. And this study, the OPTIWIN study. So these are basically formula diets. For 7 days a week, a patient is asked not to have food, but to have these formula, very low calorie diets, forming about 800 calories. Actually, in this study, the OPTIWIN study, this was conducted in America across about 15 sites using the OptiFast product, and I think they were allowed about 960 calories of the diet replacement, going up to about 1,100 if they were a BMI over 45. So in this study, they compared patients having the continuous low energy formula diet over a 26-week period to a continuous low energy diet, which was based on food, which reduced calories by about 700 calories a day. Both programs were fully supported in that first 26 weeks and then up to a year. And you can see that the weight loss was, with the food-based diet, with the energy deficit and the supported program, they were still losing about 5 or 6 kilos, but the formula diet with the continuous low energy diet actually doubled the weight loss and the weight loss success. So they were losing on average about 10 kilograms. There is a slightly greater energy deficit in this group, but the weight loss difference is more than you would expect for that. And the reasons we think these continuous low energy diets are so effective for weight loss is that they take the choice of food away from people, and the decisions that they need to make. You get good satiety after about a week, and certainly by 3 weeks you're getting patients don't feel so hungry generally on these diets. You're getting higher levels of ketones and satiety with these diets, so they don't feel so hungry, and you get rapid weight loss, and that's very motivating for patients. And so even when when that phase is finished, they're so motivated that they're more likely to carry on adhering in some way to a low-calorie diet. So these diets are certainly very effective, and this study was not just based in type 2 diabetes, but it did include some patients with pre-diabetes and type 2 diabetes. So a continuous low energy diet is certainly very effective for weight loss compared to a lower energy, a more moderate energy restricted diet. Now, obviously, we're very interested in this presentation in how these diets might help people with type 2 diabetes, and I'm sure a lot of people will be aware that patients with type 2 diabetes do face more challenges in terms of trying to lose weight. They often have a lot of psychological morbidities, and they can be on medications such as insulin, which are difficult for them to lose, more difficult and more challenging for them to lose weight with. So they do have more issues. And this is an overview which was comparing how these continuous low energy formula diets perform in patients with and without type 2 diabetes. And you can see that so if they were performing better with type 2 diabetes, the lines would be over here on the right hand side, I should say. If they were performing less well, they would be on the left. And you can see that there is no significant difference between the non-diabetic. There's possibly a slight signal that they do work slightly better in patients not on type 2 diabetes, but they certainly do work. And I think the best evidence that we have of that, as I mentioned earlier, is the DIRECT study. This was a study which was published a few years ago and conducted in the UK, and it involved about 300 patients with type 2 diabetes and obesity, conducted against around 49 primary care practices. And the patients were randomized to a weight loss program, which provided again, these continuous low energy diets of about 800 calories a day with formula feed. They did this for anything between 10 and 20 weeks. They then had a period of food introduction of between 4 and 8 weeks, and then they went into a weight maintenance phase. And the diet was fully supported with a very intensive supportive intervention delivered in primary care by the primary care nurses, which involved a lot of face-to-face contact. And the control group did receive their basic dietary advice, but they did not receive support. They just had standard diabetes management. And this study involved patients who'd been diagnosed within 4 years. So on average, they were 3 years since diagnosis. And what they were trying to look at was not only could these diets help people lose weight, but could they improve their diabetic control and actually put them into remission and get good diabetic control without the use of medications. So they had an intensive intervention for 12 months and then a still sustained supported follow-up for the next 12 months. So this is showing the overall results at 24 months. And I've just noticed there's a typo here. So actually, by the end of 24 months, the group that had been on the low energy diet and the supported program were on average about 5 kilos lighter than the control group. And the HbA1c was down by about 5 millimoles, and their blood pressure was reduced. And the important thing was that these improvements in HbA1c were seen alongside them coming off their diabetes medication, and significant numbers were going into diabetes remission. So at 12 months, it was 46%, and at 24 months, it was 30%. And again, I've just noticed another typo in this slide. I do apologise. So by the time they get to at baseline, nearly 3/4 of both groups were on medication. At 12 months, that had reduced to 26% in the continuous group, whereas it had actually gone up a little bit in the control, as you would expect with progression of disease. And by 24 months, 40% of patients in the continuous group were still on meds, compared to 84% in the control group. So, you know, the continuous low energy diet was helping with achieve significant weight loss and reductions in HbA1c, and taking people off meds, and this remission of diabetes, which is defined here as a HbA1c of less than 48 millimoles without medications. So just before I go on to talk about our MIDAS study, so a lot of the success of these continuous low energy diets is because they're very low calorie, and people are getting ketones, and they're getting rapid weight loss and feeling very motivated. So the question is, I guess, is whether, you know, whether the benefits of these diets can be achieved if you followed a food-based, very low-calorie diet versus a formula one. You know, how helpful is the formula? How important is it in that adherence and weight loss success? So this slide is showing a couple of pieces of data which try and answer that question. So the first is a randomized trial that was conducted a number of years ago with a Medifast program, and in this they randomized 90 patients with overweight or obesity, they didn't have diabetes, to either a formula 1,000 calorie diet or a food-based 1,000 calorie diet. Again, both programs were heavily supported, and for 16 weeks they were heavily supported, and then the support attenuated somewhat, so they were only having 3 monthly face-to-faces between week 17 and 40. So you can see that certainly up front the formula group were losing much more weight by the time they got to 16 weeks. Now, they were still on the formula between weeks 17 and 40 with some food introduction, but still even up to 5 formula drinks a day. But they were regaining quite a lot of weight. Both groups regained a little bit of weight with a drop in support, which we know would happen. Overall, at the end of the 40 weeks, but because they had such a great start, the formula group was still significantly losing more weight than the food-based group. So that's useful. The question is what happens over time and when they actually stop using those formula drinks. And this is a review by Norris Asprey showing that for studies of 12-month studies or longer that have compared the use of formula versus food-based diets, on average you're getting about a 2 kilogram better weight loss with a formula diet. So at 12 months there does still seem to be an advantage. But the question is, the $60 million question is, will those differences still be there 12 months down the line? So just a few summary comments before I get onto our own study about these different approaches to diet. So, you know, how easy are they to deliver? They're all certainly nutritionally adequate if you advise them properly. So in terms of ease of delivery, you know, of course, continuous diets can be followed by people out in the general population. They do better if they're supported, but they're safe for them to follow generally. Intermittent diets, again, can be self-supported, but patients on certain medications need managing on some of the diabetes medications that lower blood sugar. A continuous low energy diet requires generally medical supervision. And as I say, formula diets are, certainly effective in the short term because they remove the decision-making process for people. So in terms of adherence, I've already shown you some figures of this. So we think that, a continuous standard daily energy diet can be followed, between 25 and 40% of people long term. And the intermittent data is showing similar effects at the moment, so it doesn't seem to be better. But there is an interesting observation with intermittent diets that they actually, rather than overeating on their non-fasting days, they actually can want to eat less. So I think for a lot of people it is an effective strategy. Continuous diets, you get fantastic adherence during the actual intensive low energy diet phase. But of course they need to get back onto food at some point, and that's when they need more management. And I say that is a potential issue with formula diets. And the metabolic benefits, well, the continuous diets, weight loss will confer metabolic benefits to people, definitely. But there is this still intriguing question about whether intermittent might offer some benefits, particularly in terms of the metabolic flexibility and the fact that people seem to be better able to handle meals with greater sort of postprandial lipid responses in people who've done intermittent fasting. So that's a really interesting observation that needs more work. And of course, continuous diets with this very intensive phase of calorie restriction do seem to be helping put people in remission with type 2 diabetes. And I guess just one thing about the formula feeds is, we're all increasingly cognizant of the importance of our microbiome. And so certainly when we, as you'll see, when we have people doing formula diets, we do encourage them to have lots of fibre and vegetables alongside, rather than just a purely formula diet. So I think there are some questions to be asked about the effects of these on the microbiome. Certainly there may be short-term effects, but I think we need to see that that the microbiome does certainly get back to normal or a better state once they start normal diets. And so who can do these diets? Well, there are some groups for whom weight loss diets are definitely not or not appropriate, as you can see here. Some groups will require medical supervision. So there are people are starting to look at these all of these diets in people with kidney failure, and as we've discussed, and as you'll see, people with type 2 diabetes, which certainly prudent diets can be followed by people who are pregnant. Frail and older people need to be cognizant, of course, of the effects on their lean body mass, and there's always concern around getting people with eating disorders to diet. But we're doing some work actually in Manchester with people with gestational diabetes and intermittent diets, and I think there's still questions to be asked about the effects of these in frail older people. Certainly the evidence isn't there yet, but you would be very wary about a continuous low energy diet in those groups. So adverse effects. So one of the downsides of losing weight is that you tend to reduce your bone density. So there is a slight increase in fracture risk in people who lose weight just by the purposes of being lighter. And that you'll get that with any diet. The risks of hyper and hypoglycemia with intermittent diets, it doesn't actually seem to be any greater than with a standard daily moderate calorie restricted diet with proper management. And I guess the real question people will have is, what adverse effects do you get with these continuous 800 calorie diets? How do people feel when they do them? And certainly, if you ask any group of people over a 6-month period, if they've had any adverse effects, if they've had any headaches, if they've had any upset stomachs or fatigue, then you get 30% of patients who are not doing these diets will report those effects versus 51, so that you'll get sort of modest, a small, an increase in some of the moderate side effects. In terms of severe side effects, the most severe thing that which is not very common is actually developing problems with gallstones and biliary disorders, which only affects, as you can see, anything between 0.2 and 0.7%. And in terms of these diets with continuous low energy diets in people with on insulin, with the appropriate management, Adrian Brown's group in London did a study on this, and they showed that a continuous low energy diet compared to a standard daily calorie restricted moderate diet, there were no more hypo events in the or adverse events in the continuous low energy diets, but they were managed and medically supervised by the team. Okay, so just to summarize the first section of my talk, so intermittent diets certainly give you better short-term weight loss than a continuous diet, with some suggestions of some minor benefits in metabolic markers, but then they're well tolerated in patients with or without type 2 diabetes, and you can manage their medications perfectly well. That's fine. Continuous low energy diets are certainly very effective for weight loss, but they do generally require medical supervision, and again, they don't have few serious adverse effects. They have few serious adverse effects. Okay, so I'm going to the final part of my presentation is going to share with you a study that we conducted, myself and Dr. Basil Issa, our co-PIs on this study that we conducted in Manchester, and it's the intermittent versus continuous low energy diet app study, the MIDAS study. So as I've already shown you, there is good evidence, certainly from the direct study and others, that a continuous low energy diet using formula can induce significant weight loss and remission for type 2 diabetes. But we were interested to know whether there may be another way of doing it that may not necessarily be better, but be as good, given that, people would want potentially a different option, and not everybody would volunteer to actually follow a diet, a continuous diet for 20 weeks. And we were also intrigued to know whether if you followed an intermittent diet, perhaps that might be a better way of maintaining the weight loss after you stop doing the intensive section of the diet. So the aims of the MIDAS study it's a feasibility study, so this is not definitive proof of our research question by any means. So we wanted to assess the feasibility and the potential efficacy of an intermittent low energy diet and a continuous low energy diet that was they were isoenergetic, and our program was remotely delivered, and we started doing this study way before COVID hit, so it's been it's obviously very, very relevant now. So we wanted to test the feasibility of the two approaches. So the primary outcomes at the end of the 52-week study were we wanted to look at where we looked at the uptake to the trial, the retention, the number of patients who had an HbA1c of less than 48, and whether we had significant numbers of patients achieving significant weight loss of 10 or 15%. And secondary outcomes were, were people able to follow these diets, adverse effects, and changes to diabetes medication, and whether they were using the remote technology, which was the Aviva app that they were supported with. So the diets. So as I say, we used the OptiFast low energy formula diet for both groups. So the continuous low energy diet group had 40 participants in, and for 8 weeks and 7 days a week, they were asked to follow an 800 calorie diet, which involved 3 of the OptiFast sachets and about 7 portions of vegetables. And they had a step food reintroduction of with actual foods. We took them off the drinks totally, and that was built between 1,000 and 1,500 calories over 4 weeks. And they had then 40 weeks of a continued weight loss or a weight maintenance phase, which was a daily calorie-controlled Mediterranean diet. So the intermittent group, so it was an isocaloric diet. So they again had the formula feed, but they had their 56 days of low-calorie diet, OptiFast diet, spread over 28 weeks. So they had 2 days a week of this this diet, this 800-calorie diet, again involving the drinks and the vegetables. And for 5 days a week, they were asked to follow a portion-controlled Mediterranean diet. And at the end of that period, at the 28 weeks, they had a continued weight loss or weight maintenance period where they were still asked to do a food-based intermittent diet, not the drinks. If they regained weight at any point during the study, they could go back on their original diets for a couple of weeks. So in terms of medication management, we did reduce a lot of their diabetes and hypertensive medications when they started doing these diets, as you do when people are losing weight loss. But we maintained patients on metformin because there is good evidence that metformin can actually be very effective in the prevention of diabetes. So it seemed like a sensible thing to do, the best thing for the patients, to keep them on the metformin, but certainly reduce some of the other medications. And on the intermittent diets, they stopped the diabetes medication on their low energy days, but not on the other days. So they had a variable medicine management protocol, and they had support. Not as much as you saw in the direct study. We were trying to do a sort of more real world study. I say it's remotely delivered, and they had as a multidisciplinary group. So they had the diabetes dietitian, spoke to them originally weekly, then fortnightly, then certainly in the last 6 months, it dropped to monthly contact, which was just quite often a text. The patients on medications had diabetes nurse interaction. All patients had an exercise consultations remotely, and patients who scored highly with anxiety and depression and low self-efficacy, which was actually about 45% of our cohort, had interventions from the psychologist. So the eligibility criteria for our study, we included people who were up to 8 years of being diagnosed with diabetes, and they were of age between 18 and 75, and BMI up to 50. So here are the characteristics of our intermittent and continuous low energy groups. So notable points here are we did actually manage to include more ethnic patients in our study than perhaps some that you would see in the UK. So a quarter of our intermittent group were from different ethnic groups, and we had a range of patients, some who were just on diet alone, and some who were on insulin. We included insulin patients, which again weren't included in the previous direct study. And as I've already mentioned, significant. So we had significant numbers of the patients actually with quite high psychological morbidity. So this was trying to be a real world study and include the breadth of patients that we see in the clinic. And we recruited patients from primary care and from the tertiary, from the hospital site. You can see that we recruited, nearly a third from each of those, and some were self-referred from a register and word of mouth. And so the uptake was pretty good. So we we estimate from the number of people who were invited from the GP practices that the uptake was about 35% in primary care, and from the hospital about 20%, which is not bad. And retention was pretty good. So at 12 months, we had very similar retention of around 70% in both groups. Okay, so what happened to the weight loss? This is an intention to treat analysis. So patients who've left the study have been built into this with intention to treat modelling. And so you can see this is their weight. So the intermittent group is in grey and the continuous group is in blue. So not surprisingly, at the end of 12 weeks, the continuous group are achieving much more weight loss than the intermittent group, because they've done pretty much most of their dieting by that phase. They've done their low energy days. By 6 months, both groups have done the same number of low energy days, or certainly been asked to do the same number of days. And you can see the weight loss is equivalent at around about 7%. Both groups regain some weight, but at the end of the 52-week, 12-month period, both groups are losing very similar amounts of weight. This is not a powered study, so we're not showing significance here, but you can see numerically the groups are performing very similarly. And we've got 42% of both groups achieving an HbA1c of less than 48. Now, of course, some of them are still on metformin, so it's not a comparable figure perhaps to the direct study of 46% you saw earlier. And in terms of significant weight loss, we're getting about 20% losing 10% or more, and 6 and 4% losing 15% or more. And nice reductions in HbA1c of around 8 millimoles. And it's worth noting that this is achieved in the continuous group with a reduction in medication. This is MES is the medication effect score, which is a formula which computes the amount of hypoglycemic medication somebody, the type of medication they're on, and the amount of it, and it gives you a sort of global glucose lowering score of that medication. And you can see the continuous group improved their HbA1c with a reduction in this. There wasn't a reduction in the medication score for the intermittent group, which is interesting. There may be a difference between the two approaches in terms of its effect on diabetes remission, although I think we need to be careful with the small numbers here. We did have slightly different balances of medications at the start in these. These groups have only got sort of 39 and 40 patients each. So it may be that, some of the differences we're seeing here is just some of those, some patients, small numbers of patients driving these differences. But I think it's an interesting question. And so at the end of 52 weeks, you can see we had people that decreased their medications were 40% of the continuous group versus only 11% of the intermittent group. And actually some of the intermittent group got worse, which is what, you would expect a lot of patients to normally get worse. Significant numbers maintained. So there does seem to be equivalent weight loss, equivalent reductions in HbA1c, but maybe slightly better reductions in medication in the continuous group here. So so other key outcomes are, did people actually follow these diets? Well, we've only got self-report data, but according to our patients, then they were doing on, certainly when they were doing the very low energy days with the formula diet, we were getting really good compliance of about 80% in the intermittent group and 90% in the continuous group. And but then when we asked them to do a food-based intermittent diet, I think the reason that they didn't do so well in terms of maintaining their weight loss and the metabolic benefits is that we only had a third of them doing that, and whether that would be improved if we asked them to carry on with a formula at that point is an important question. there weren't many adverse events. There were serious adverse events. There were 4 in each, of which only 1 was related to the diet, we think, which was gallbladder issues, which are a known, as I've previously mentioned, sort of unusual, but are a known side effect or potential side effect of these continuous diets. And there was a good uptake to the remote technology. So we had 80% of patients using the app. And one thing that we didn't actually use until partway through the study, which I think would improve our outcomes, was that there's an option of having a patient peer support forum. And when we asked people sort of partway through the study, we got half of them signing up to that. So I think if we'd brought that in at the start, I think we may have done better. Okay, so the conclusions from our MIDAS study are we've certainly shown the feasibility of remotely delivered intermittent and continuous low energy diet programs, and that they can improve weight loss and reduce HbA1c and reduce medications for type 2 diabetes. And intermittent diets certainly could be an effective alternative to continuous low energy diets. And we've shown that these diets can work in a real world situation in quite complex patients with a lot of psychological issues and people who are diagnosed for up to 8 years and patients on insulin. So obviously we've, there's a lot of questions that we do need to answer that I've alluded to as I've gone through this presentation. So we definitely need more, as ever, larger, longer term trials. There's loads of 3-month trials out there. And to be honest, a lot of people can do any diet for 3 months. I think we really need to develop strategies to keep people doing it for a lot longer. That's where that's where we need to be. That's where the benefits will be reaped. And, again, with a lot of research, a lot of research is done in Caucasian populations. We've certainly got a good split of male and female in a lot of the diabetes studies, but we need to look in different ethnic groups and patients with gestational diabetes and type 1 diabetes. We're starting to look at these diets and we need to understand, how these diets actually work in terms of diabetes remission. Is it just the reductions in hepatic and liver fat, or is there, as been alluded to by some work by, preclinical work by Paul Longo, some pancreatic regeneration that you get with low intermittent or low energy diets? So all fascinating questions. So before I sign off, I'd just like to acknowledge, of course, the people that funded the MIDAS study, which was Nestle and Aviva, and of course our trial participants who are prepared to do these diets and take part, and the MIDAS team, my co-PI Basil Issa, and the team, Sarah McDermott, who's worked tirelessly supporting, and Avni supporting these patients, and Sarah helping write up the results. And yeah, we had a fantastic multidisciplinary team working on the study. So thank you, and I think we're going to take any questions.
Thank you, Dr. Harvie, for your excellent and really very interesting talk. I definitely learned some new things today. So what we're going to do just in the last 6-7 minutes, we will switch over to the live Q&A, and we'll try to address as many as we can in the time that's remaining. But we can also try to follow up on questions if we do not get to them. So I will just hand it back over to Dr. Harvie.
Okay, thank you. So, yeah, we've got some questions here. So the first one is, how many days of intermittent fasting in a week is recommended to lose weight in obesity? So, say our model is 2 days a week, which is shown to be very, very effective. Krista, the other version is alternate day fasting, which I guess it depends. I guess it's anything between 3 and 4 days a week, but I don't yet. You wouldn't. It's probably more like 3 days a week. But I think if you end up doing more than that, then you're not doing an intermittent intermittent diet, and our days are generally together unless somebody's got a particular medical problem where you might want them to separate them. But we find in terms of adherence, people often find it easier to do them together. Okay, so so there's a question about intermittent fasting for patients with PCOS and insulin resistance, and I'm not familiar with a specific study on that, and I do apologize if there is one out there. But I mean, one of the things that these diets certainly do seem to be good about is improving insulin sensitivity, particularly with the hepatic insulin sensitivity. When you do the diets, you actually get free fatty acid release and a sort of an apparent reduction in peripheral insulin sensitivity, but they seem to be good for hepatics, so it may well be, but I'm not totally sure there has been a specific study in PCOS. I'm sure there will be. Okay, so there's a question here about restrictive time intermittent dieting. So this is the idea that rather than focusing on certain days of dieting and not others, you ask people to limit their food intake to anything between a 6, 8, 10 hour window. So in terms of actually reducing people's intake, then it does work. It works better when you actually give people advice about what to eat, and that's been borne out in a few studies recently. The TREAT study, where they didn't do that, showed very marginal benefits. So, and there are some intriguing studies done by Eric Raverson's group, showing that certainly in people with pre-diabetes, even if you don't restrict calories, then having time-restricted feeding window of between 6 and 8 hours, particularly at the early part of the day, can induce metabolic benefits. So I think it's something that we do need to do a lot more work of. But I think the idea that people can eat exactly what they want in a 6-hour window and lose weight and be metabolically healthy is a bit of a nonsense. It's what you see in the animal studies, but there's something else going on there in terms of their circadian rhythm, I think. So yeah, so time restricted feeding is a strategy people can use, but they need advice on the types of food to eat. And you do need concern with people who are older and frail, because you might lose lean body mass with those interventions. So, okay, so this question. So no one's debating whether a low energy diet causes weight loss improvements in type 2 in the short term. Do the results persist? Is the rebound effect worse? Okay, so I think this whole, we know that if patients lose weight and regain it psychologically, that's bad for them, but there's very little good evidence that patients that even when they do regain weight, they generally don't regain it all, and they don't seem to regain it preferentially in some of the bad fat store places. So I think this is one of the arguments that people often put forward to suggest that it's unethical to ask people to try and lose weight, because when they relapse, they end up in a worse state than when they started. I think perhaps from a confidence and self-efficacy point of view, that is true, which is why we need to spend a lot of time and effort developing interventions that really give them the best chance of succeeding long-term and long-term support. But from a metabolic standpoint, there's no evidence of that, and people have studied those sort of post-obese and rebound patients, and they don't seem to be any worse. But we do need to do more work about long-term support. It may be that people just need a constant, even low intensity ongoing support, or certainly some patients do, and that would be worth doing to stop these rebounds. Okay, so does the intermittent, very low energy diet cause hypoglycemia, and how can patients manage the medication between the fasting and non-fasting days? So this depends on the medications that people are on, and there are good protocols published. Certainly, Peter Clifton's group and Carter is the first author, have published quite a lot of protocols where they've studied obviously switching medications between fasting and non-fasting days, and those are we adapted those to use in our own MIDAS study. So yes, the answer is yes, they can be managed, but they do need to use these protocols, and patients can't just self-manage themselves. Obviously, patients who are on medications which don't cause hypoglycemia, such as metformin, or if they're just on diet alone, or even some of the other agents. It's mainly the patients on insulin and some of the sulfonylureas that where the problem of hypoglycemia comes in, and those are the medications you need to particularly manage. But yeah, I'd refer you to those papers on medicine management. Okay, so there's a question here: how does the CELED diet with Optifast time, four sachets of Optifast a day compared with 3 sachets a day in an evening meal? There's probably not a great deal of difference. An Optifast sachet contains it's 216 calories now, so it's probably very, very similar nutritionally, and I would think probably adherence wise, I would imagine that both strategies will work very well. As I say, we're always very keen to not just have people on sachets, but to certainly encourage them to have the vegetables as well as their formula drinks. I think that instills, it gives you a bit of a fighting chance of getting them back on normal diet, as well as potentially helping with the fibre and preventing constipation during the diet and helping with the microbiome. It gets them used to sort of eating normally, eating more veg than they've probably ever done in their life. Okay, so do you have any data on how patients deal with hunger and managing hunger in alternative diet approaches for weight? So one of the intriguing things about intermittent dieting is that patients don't seem to, or people doing it, don't seem to feel particularly hungry the day after their diet. The odd person does, and maybe the first few times they do, but people get used to following these diets and they actually feel less hungry the day after. And we don't really understand why. I think a lot of that may be behavioural, but there may be some physiological reasons why that they're feeling like that. But it's a very interesting observation. It's one of the reasons I think people perhaps didn't want to do these diets originally, because they thought people would overeat and it would encourage a binge sort of cycle. But it doesn't seem to. In majority of people, they actually want to eat less on the other days, and that's why, certainly in our hands, these diets do seem to be very, very effective. Okay, so I think I've probably answered all the questions.
All right. So thank you. Yes, I know we went a little bit over. So thank you again. I'd like to also thank all the participants for your interest in taking time out of your day to attend. If there are any additional questions, as I mentioned, we will try to see if we can address them. You can also reach out to your contact and try to communicate questions to me. And then there will be a recording made available probably within 2 to 3 days, and it will be in the archives. So thank you again, and I hope everyone has a nice rest of their evening or day. Bye-bye.